Hello, everyone. My name is Ghayth Alawwa. I'm a research fellow at the Mount Sinai Hospital in New York. Thank you for allowing me this chance to present today in these unprecedented times. I'm going to talk about the experience we have at Mount Sinai with the transoral endoscopic thyroidectomy via vestibular approach, or TOEDVA, as an ambulatory procedure. I have nothing to disclose. I will start by outlining the history of open thyroid surgery as an ambulatory procedure, a brief review of TOEDVA, and discuss our experience with this procedure when done on an outpatient basis. The conventional open thyroidectomy via the transcervical route remains the standard of care worldwide for various thyroid diseases. Open thyroidectomy has also been widely accepted as an outpatient procedure, as was emphasized by the American Thyroid Association consensus statement on outpatient thyroidectomy when performed on carefully selected patients. The main concerns to adopting an ambulatory thyroidectomy approach are the potential to develop postoperative hemorrhage, bilateral laryngeal nerve paralysis, and/or severe hypocalcemia. All three represent potential life-threatening complications, and if developed, they may require monitoring and intervention in an inpatient setting. The ability to overcome these obstacles and perform the procedure safely on an outpatient basis has the potential to decrease cost, nosocomial infection rates, and iatrogenic complications. When performing any outpatient procedure, the main concern remains patient safety and formulating criteria for a safe discharge. Outpatient thyroid surgery has been performed and studied thoroughly over the last decade with favorable outcomes. There are clearly defined parameters regarding patient selection, preoperative, intraoperative, and postoperative factors that play a role in a successful outpatient thyroidectomy. The question we posed was, can we develop a similar protocol to the transoral approach that would be safe and feasible to allow same-day discharge? TOEDVA is a minimally invasive technique to performing a thyroidectomy without a cutaneous scar. It's performed through standard laparoscopic instruments utilizing 3 incisions on the vestibule, as shown in the figure. Since its development in 2008, it has gained popularity and has been shown to be safe and feasible with similar outcomes to the standard thyroidectomy, while also yielding ideal cosmetic results and avoiding a cervical scar. The length of stay after thyroid surgery, whether open or transoral, is variable depending on the medical condition of the patient, perioperative, geographic, and sociocultural factors. It is different in the United States compared to other parts of the world and Asia where this procedure was developed. As for open thyroidectomy, a customized protocol should be designed to help decide and select patients who may be good candidates for ambulatory TOEDVA. 140 patients who underwent a planned ambulatory open thyroidectomy or TOEDVA between 2014 and 2019 were identified and retrospectively studied. All patients underwent a similar standardized protocol for same-day discharge at the same institution. Outcomes between the two groups, including length of stay, operative time, estimated blood loss, and postoperative complications, were compared. Patients were followed from up to 2 weeks to 2 years postoperatively. The protocol starts with general and preoperative considerations. Selected patients should be medically fit and have no significant comorbidities. They all have an accessible caregiver who is capable of understanding post-op complications and instructions. All patients should also be given preoperative education and counseling about what to expect before and after surgery. Intraoperatively, important factors include not selecting patients with massive goiters, extensive retrosternal extension, or locally advanced malignancy, identifying and preserving the parathyroid glands, monitoring and confirming the integrity of the recurrent laryngeal nerve, and using safe surgical technique with careful hemostasis. Finally, postoperatively prior to discharge, patients are assessed clinically for vocal cord function and neck swelling. They are provided oral outpatient calcium, and it's confirmed that they have an easy and fast access to the hospital with direct communication with the operating surgeon. This is performed over 3 hours, 2 hours in the immediate recovery area with cardiorespiratory monitoring, and 1 hour in the step-down recovery area where the patient is allowed to have an oral diet and ambulates. The patients are discharged home if their vital signs and voice are normal, pain and nausea are controlled, and they're able to ambulate and tolerate the diet. Details about the patient's population and demographics is summarized in the table above. The two groups were similar in the mean age, gender, BMI, preoperative diagnosis, and tumor size. Table 2 summarizes the operative details. 49 patients underwent a transoral lobectomy, and 43 patients underwent an open lobectomy, with the remaining undergoing a total thyroidectomy. There was no significant difference in the length of stay, with most patients going home within 24 hours of the procedure. 60 patients in the open group compared to 59 patients in the Thywaitekva group. 10 patients in the Thywaitekva group who did not meet criteria for safe ambulatory discharge required an overnight stay, and 1 patient required admission for 3 nights to control her pain and oral discomfort. Patients who did not fit criteria for a safe discharge did not do so due to having oral discomfort and pain, not having an adequate caregiver support, or living in remote areas. Most importantly, none of the patients in both groups developed clinically significant hemorrhage, airway compromise, or hypocalcemia requiring admission or re-intervention. In conclusion, Thywaitekva is a relatively new technique with a steep learning curve, but it can be safely performed as an ambulatory procedure in carefully selected patients. It provides equivalent outcomes to the traditional open approach with no increased risk of postoperative complications and superior cosmetic results. Special thanks to Dr. Gustavo Fernandez for adopting, implementing, and teaching this technique, as well as the entire research team at Mount Sinai. Thank you very much for your time.